Can you hear me okay? Okay, sounds okay. So I'm going to go talk a little bit today about consent and specifically focusing in the end on waiver of consent and exception from informed consent. And on that last one, I'm going to talk a little bit about a specific case that we had a while back. But I'm going to start off with by talking a little bit in general about human subjects and human subjects research and the ethics of human subjects. Some of you have probably seen some of these slides before because we use them. But I'm going to start off by saying a little bit about the historical perspective and give you a sense of that. And then I'm going to talk a little bit about some of the federal regulations to put it into context. Then a brief discussion on waiver and exception from informed consent, and a little bit of focus and a little bit of repetition for some of you perhaps about our program here, and then a specific example of exception from informed consent. So this is one of our favorite slides, Dr. Rosenthal and mine, because we're really, when you talk about human subjects research and the ethics of human subjects research, what you're trying to do is really balance two specific goals. Now the first goal is you're trying to advance science. You're trying to advance knowledge, get generalizable information that you'll be able to publish and utilize to improve the care that we're delivering. But on the other side of that, you have to make sure that you're protecting human subjects. And so this is really the kind of balance that we're struggling with all the time as we look at the IRB approval of protocols and making sure that the research that's being done is ethical, appropriate, and something that we can approve. Now, I'd love to say that this is not a necessary task, but unfortunately, at least the last 100 years or so, it's been very clear that there have been a number of lapses in terms of considerations for human subjects. This is a picture from the Nuremberg trials. And in Nuremberg, during World War II, both the Germans and the Japanese, and probably others, though we may not know, did human subject experiments. They'd throw them out into the cold to see how long it took them to freeze. And really, they did a lot of things that is very clear were unethical and without consent. So as a result, from the Nuremberg, they developed a code. And the Nuremberg Code specifically highlights the fact that voluntary consent of human subjects is absolutely essential. People have to be willing to participate in. You can't just blithely experiment on them, okay? In that informed consent process, there should be no coercion. They should be able to make a free and rational decision about whether or not they want to participate. They must be able to stop at any time if that's what they feel is appropriate. And ideally, when you're doing research, you want to make sure that there's pre-existing animal or preclinical data that's going to allow you to justify experimenting on people. Okay? You got to make sure that scientific value, that the anticipated risk anticipated results justify the risk. Really, risk-benefit ratio, which you'll hear me talk about quite a bit. Okay? And then you want to make sure that you really avoid suffering of subjects and no expectation of death or disability. So this is 1947. So this is 70 years ago or so. And we learned that there's really a difference between medical practice and research. Medical practice, as a physician, as a clinician, I have a fair amount of latitude about what I prescribe and what I do because I'm doing what I consider in the best judgment for the patient. My obligation is to the patient. I'm supposed to try to help them. Patient historically is silent, dutifully obedient to the beneficent physician. I'm not sure where that is currently, but that may have been a historical perspective. Whereas research is a little bit outside of that. Because when you look at research is, I'm trying to answer a specific question. I'm trying to figure out what is the best in terms of my different options from a research perspective. And if you look at those, there's a little bit of a conflict of roles. So I'm trying to do the best for my patient as a physician, yet I'm trying to do the best research I can. And what happens if those roles conflict? So recognizing, progression of time, 1947 to 1964, and recognizing that that what was started with Nuremberg was great, but it wasn't enough. And so in the World Medical Association developed in the Declaration of Helsinki, which has been updated multiple times since then, and they made some adjustments to the facts. So they recognize that consent, not everyone's capable of giving consent. And there may be some issues with that. So for example, a child may not be able to give consent, or someone who's had brain injury. But there are other folks as well. So for example, someone who's a prisoner may theoretically have the capability of giving consent, but they don't have the societal capacity because that's been taken away from them to be able to make a decision. So consent may not always be possible. So here we've got a dynamic. So you've got the Nuremberg that clearly states everyone needs to give informed consent, yet a recognition 30 years later that informed consent may not be possible. I'd love to say, we learned our lesson, we're doing it all right, but then 8 years later come along Tuskegee. Now, I'm sure everyone knows Tuskegee, but let's highlight some points, okay? The issue with Tuskegee is that in 1932, when they started the study, they didn't know how to treat syphilis. Okay? The informed consent process was hardly at all. But as time progressed, the subjects weren't informed of the fact that there were now treatments for syphilis. They thought that the spinal taps they were getting were part of treatment. The U.S. government actively prevented people from getting treated. And it was only after this was exposed to the light of day, and again, these weren't some researchers out in the middle of nowhere. This was CDC. This was the federal government that was doing this research. Okay, and it was only from press reports that the government finally stopped. So what happened from this? The next thing that happened was, as a result of this, the federal government had a number of groups together to look at human subject ethics and research ethics, to figure out how they're going to put this together. And they developed the Belmont Report, which came out in 1979. And there are three key components, three key principles. There's autonomy, beneficence, and justice, and the development of the common rule, which at the time there were no exception for emergencies. So respect for persons. I, as an individual, have autonomy. I need to be able to make a decision about whether I want to be part of the research. So you have to respect my decision. If I say no, then I say no. Beneficence. You have to, again, the issue of maximizing benefit and minimizing risk. And then finally, justice. It's unethical for me to be doing experiments and putting human subjects at risk in one population, but giving the benefits to another population. So that's when you talk about justice. But as I said here, there was no exception for emergencies. So what happens if you can't get informed consent? What happens if the people are in a state that it's an emergency, you want to deliver life-threatening care, but you can't give informed consent? Okay? So a group of knowledgeable, experienced emergency physicians came together and published in JAMA a consensus statement about this. Okay? So there was a recognition that you can't do research without informed consent. Not everybody's able to give informed consent for various reasons, and there may be some populations in which informed consent, in which you want to be able to do research to find life-threatening cures, yet you're not able to get that informed consent. So clearly, again, there's a dynamic, there's a tension, there's how do you resolve some of these things, okay? And so the Code of Federal Regulations came out, and there are some very specific guidelines for exception from informed consent for emergency research. Again, medical practice is to enhance the well-being of the patient. Experimental is defined as new, untested, and or different. But I can experiment without it being research. What research is systematic investigation designed to produce generalizable knowledge. Okay? So one of the things that we get asked all the time is, I just want to do a QA project. Do I need an IRB protocol? Do I need IRB approval? So what do you guys think? If I was just doing a QA project, do I need IRB approval? Come on. Someone raise their hands, volunteer. Do I need IRB approval if I'm doing a QA project? Go ahead.
Do you want to present that outside the university? Like, do you want, even though it's QA, if you're actually going to present it outside or publish it?
So what he's getting at here is really the question of, generalizable knowledge. If I'm doing a QA project looking at what's happening in my emergency department and just to kind of inform my colleagues about how we can do something better, no, I don't need to get IRB approval. But if I want to take that exact same project and present it at a scientific conference, then I need IRB approval. And the key here is don't ask us in the IRB to approve something you've already done. If you think you might want to present it, a lot of conditional there, but if you're planning at all to have that as consideration, then get IRB approval to start with. It's just easier that way. Otherwise, we cannot retrospectively approve research. So the other component of definitions in the Federal Register and Federal Regulation is what's a human subject. Now, a human subject is someone you either having interactions with to collect data, or you collect identifiable private information. So if I'm collecting information about people who have passed away, it's not human subject research. However, HIPAA may apply, so there are other rules or regulations. So as a general rule, we're going to need to look at those as also from the IRB perspective. But in terms of human subjects, they're not by definition human subjects. So from the IRB and Human Research Protection Program perspective, what we're trying to do is kind of balance the issues of benefit and risk to make sure that when you put your research together, it's ethical, appropriate, and scientifically appropriate as well. We'll look at the science because would it be ethical to do research to get generalizable knowledge if there was no way to get generalizable knowledge? If the study is so bad that you're putting people at risk without any likelihood of getting either direct benefit or indirect benefit? So that's one of the things, that's why sometimes we're asked, why do you look at the science? And the issue is that we can't approve something that doesn't scientifically make sense. Again, the risk-benefit ratio. So I don't want to go through the whole process of informed consent. There's a lot of things in the informed consent document that we have to put in there because it's required or expected. But let me ask you something. I have my own personal opinion. Do you think a 35-page informed consent document with lots of information is really informed consent? But this is what we approve, okay? And I'll say there is some literature now to show that perhaps shorter, abbreviated, simpler forms might be just as informed. So the informed consent document itself is not informed consent. It's a process. Have you sat down? Have you explained the research to the people? Do they understand? Do you have some way of proving that they understand that research? The signature on that consent form is simply an acknowledgement that you've gone through the process, but it does not stop there. You need to disclose the potential research, make sure that they facilitate their understanding, and promote the voluntariness of the decision. So these are really the three critical components. And if you want, there's a whole mess more at the government website in terms of answers. Yes, go ahead.
Well, I guess the question with that is, if you do have a 35-page informed consent, any sort of winnowing down of that or creation of an executive summary is a subjective process. So it's kind of an all or nothing, in my opinion. You know, either you give them the full vote or somebody's making a decision as to what the patient should or should, what the subject, should or should not be exposed to in the shorter version of it. Well,
why can't you do both? Why don't you have an executive summary? They can have the whole full thing to review at their leisure. But if you
just to play devil's advocate, at that point, we know human nature, and we know that 99.32%, we've done studies now, people aren't going to read the bigger document. However, if you walk them through the bigger document as the primary, then that to me is informed consent. If you give them a 12-page or a 6-page document, whatever if you choose, that to me they're not going to go to the larger document. They've got other stressors on their minds, other worries on their mind.
But you said you walked them through. So therefore, you're highlighting specific areas. You're saying, this is what I want you to look at. So even in that process...
We walk them through from the first letter to the last period. Informed consent to me. That is...
And I'm not going to sit here and have a long argument about it. I think that you're quite legitimate to have your perspective on it. However, what I would say is that in terms of much of a 35-page complex protocol, the amount of true comprehension, I would have to question.
Well, protocol or ICF?
in terms of the information that's in the ICF. But again, I'm not going to sit and argue. If you think that's what's appropriate for the studies that you're doing, and you're going to sit there and have that long conversation, it's not the document. It's the process. And it's to assure that they have a good understanding of what's going on, and you facilitated that they can make an informed decision, and that it's a voluntary informed decision. Then if that's the way you feel that it works for you, then that's great. Okay? However, I would say that there are many people who 35-page complex protocol may not work for them. So we've talked a little bit about informed consent and why we have informed consent. We've talked a little bit about the federal regulation, and I want to highlight two things in the federal regulation to be clear in terms of informed consent, and when you don't perhaps need to get informed consent, or why there may be an exception or a waiver. The first is the one that we most commonly see, which is a waiver or alteration of informed consent, subpart 46.116D. Okay? There are 4 conditions for us to be able to grant a waiver or alteration of informed consent. Okay? The first is that it has to be minimal risk. And I'll talk a bit, give you what this is. Okay? The second is that waiver will not adversely affect the rights and welfare of the subjects. Okay? The third is that it cannot practically be carried out without the waiver or alteration. And the last is that whenever appropriate, subjects will be provided additional pertinent information. Now, this is the language out of the Federal Registrar. So we have to interpret that language. That's part of what the IRB does. Sometimes there's more information in the IRB, sometimes there's less. Or more information in the Federal Register, and sometimes there's less. So for example, for minimal risk research, there's a nice paragraph. Now, we still have to interpret what this means. There's the risks are no more than what you would see on routine physical or psychological examinations or tests. And so there's a certain amount of interpretation. Okay? So ultrasound is considered minimal risk because it's not considered very high risk. If I do any type of ionizing radiation, even the smallest amount with a DEXA scan, that's greater than minimal risk. Okay? Some places you go and they'll say MRI is minimal risk. Other places it's greater than minimal risk. There's a certain amount of discretion in terms of the people who review this. The type of things that we see here as minimal risk are things like chart review, surveys, physical exam, drawing blood, review of previously collected specimen, collection of stool, or non-invasive collection of specimens. Drawing blood is an interesting one. So for example, if you have an IV and you draw blood, that's minimal risk. If you put an IV in to do multiple bloods, then IV is considered not something you'd see on a normal physical exam or psychological test, and we tend to consider that greater than minimal risk. Now, just maybe marginally greater than minimal risk, but still greater than minimal risk. So this is the first condition. Okay? Adversely affect the rights and welfare of subjects. Well, when would that be? This is, I think, a little more open to interpretation, but the example that's given, there's a Secretary's Advisory Council on Human Research Protection, and there's some documents that they've put out there which are kind of advisory letters to the Office of Human Research Protection, but not necessarily placed into Federal Registrar. And one of the examples they gave here is if you were doing research on education, and you've decided that you want to look at everyone's grades, and you know exactly what their grades were and how they did, well, I think I would feel violated, others may feel violated if someone's going to that level of knowledge related to how I did in school. So that might be affecting the rights and welfare. But again, this is very much open for interpretation. The third is that it can't be practically carried out. This does not mean it's too much work to get the informed consent. This means that the research for scientific reasons could not be practically carried out if you had to go and get consent. What's an example this is one we see all the time. A retrospective chart review of 10,000 records. Okay, these are folks that have already come to the hospital. They may or may not be contactable. We won't be able to do it. That to us is an example of a not practically, a research that can't be practically done. And this is the type of thing that we tend to see when we look at waiver or alteration of informed consent. Okay. Another example is, let's say I'm doing research on rape victims, okay? And the only bit of linkage that I would have would be their signed consent. In that instance, we may alter or waive the requirement of written documentation because that document increases their risk as opposed to decreases it. And these are all important. When you put your protocol in, and these are the type of research you're doing, this is what we need to look at and understand so that when we try to approve it, we can give a reasonable justification as to why you should get a waiver or alteration of informed consent. And then when appropriate, you give additional information to the subjects. Now, when would this come in? So for example, sometimes, and this is relatively rare, someone will do a deception study. So I know of one study in which they were looking to see, they were doing a simulation in an emergency condition, and one group, the patient lived, and the other group, the patient died. Okay? But they couldn't tell them this in advance because part of it was to see whether or not they would retain knowledge more if the patient passed away in this simulation. So that was a deception. So in the informed consent, wasn't really a fully informed consent when they signed to do the research, and they were informed about that afterwards. So that would be an example of where we would need to give them information after the informed consent. Or for example, you're doing a research review and you realize that there's a pattern in the research that you're doing that you have just identified an important risk for the population you're looking at. And even though this was a retrospective chart review, because this is important information, you need to be able to notify those folks. So those are kind of examples. And again, all 4 conditions must be met for us to be able to offer a waiver or alteration of informed consent. Okay? Any questions on this? This is what we commonly see. This is what we are most often asked to review from a waiver of informed consent. Let me go to the other extreme. So that was all minimal risk stuff. The very minimal risk stuff. There's what's exception from informed consent. This is an emergency condition. Okay. One is we're waiving your need to get informed consent. In this, you're getting an exception from getting informed consent. So after the recognition, the Belmont report and everything else, the recognition that there wasn't, and the common rule, there wasn't an exception for emergency conditions, they came back and developed that in a life-threatening situation where available treatments are unproven or unsatisfactory, then you can request an exception from informed consent. So in this instance where you've got someone who's got a life-threatening condition and we're not sure what the best treatment is, you can make a request from the IRB to get an exception from informed consent. Now, that request is a complicated process. It's not as simple, yeah, you can just do it, no problem. It requires a number of steps. So first you have to document that you can't get consent. Consent's not feasible, okay? That the subjects are in a life-threatening situation, that the treatment is unclear, and that you've got prior research to indicate that there's a potential for this. Okay? And the risk-benefit ratio is reasonable. In addition to the fact there's a life-threatening problem, you have to have a short therapeutic window, because if it's a long window, then I could work on getting the consent at a later time. Okay? And you'll make all the efforts as the researcher to be sure to get informed consent if possible. Okay? Now, we'll review the informed consent process, even if in the end you're not going to get informed consent. So we have, from the IRB perspective, can grant that exception from informed consent, but even with that granting, you still have to have the whole informed consent process clearly spelled out. So what's going to happen? Well, to meet the requirements, you have to do what's called a consultation with the community. Okay? This is not asking community's permission, because informed consent is on an individual basis. You're giving someone information on an individual basis to be able to make a rational judgment, a voluntary decision about whether or not they'd be involved. You can't ask a community to give informed consent for an individual. But what you can do is you can go to that community and say, look, we want to do this research. Okay? This research is a life-threatening problem, and we won't be able to get consent. And we want to discuss that. So it has to be a kind of a dialogue, a two-way conversation. Okay? You need to publicly disclose to the community you're going to do this research. Establish an independent data monitoring committee. And you really, in this whole process, you have to be very clear in terms of the communication with who and how. Okay? So let me ask you this. What's community consultation? What's an example of community consultation? Any thoughts? Go ahead.
Well, in our international studies, we have to get approval from the chiefs in the community to allow us to go in and recruit from the villages.
All right, so you've consulted with the head person. That would work in certain situations. It may not work here. So what are other examples of potential community consultation? How would you do it? Go ahead.
Getting a large cross-section of your community at an event and surveying them for their opinions on whether or not they would find the research to be acceptable.
So somehow approaching them to get some type of collection of information so that you can understand what their perspectives are. What else? I wish I had a good answer for you, but community, go ahead.
I was going to say like cultural studies, you know, making broad inquiry to people of various cultures.
Right. So I wish there was a good answer, but first of all, you have to define what the community is, okay? And that community in a developing country may be different from a community here in Baltimore. And it may be different depending on my condition or disease. So if I'm looking at trauma patients and have a life-threatening, then trauma patients here may come from around the state. So I may have to do some type of process that involves the whole state, okay? But this community consultation plan will be submitted to the IRB. We'll review it and work with you. Because we can't approve the exception from informed consent until you've gone through all of these steps. So it's a back and forth and multiple times. Okay? So that community consultation could be talking to people at a specific population that has a specific disease, so going to a clinic where they're at. It may be going to a church here and talking to the community, related to their interest and all. But there has to be a two-way conversation. There should be community information as well, and you may do public service announcements and things like that. But again, it's really a conversation, and that's what it's about. You're not asking for permission. They cannot give consent to enroll any individual. But what you can do is engage them in a conversation, make sure they have an understanding of what's going on and why you're doing the research, and then you listen to them to see what their concerns and issues are. So I'm going to take a step away from this, and I want to talk a little bit about the structure that we have here, just as a refresher for some of you, and so that when I talk about the last little bit about what we've done here, you'll have some understanding. So we have the Human Research Protections Program, which is split into the Human Research Protections Office and the IRB. Okay? The HRPO is the function that does kind of most of the administrative stuff. They're the ones that often do the pre-reviews. They make sure that the IRB meetings put together. They have an incredible amount of knowledge related to the regulations and also what is likely to be approved and what's not. And when you put in a consent form, or put in a protocol, they're great people to have a conversation with to make sure that you put it together. And it's supported. We have over 2,000 research protocols. Clinical includes both minimal risk and greater than minimal risk. Okay? Our mission is, the protection and plan is to protect human rights and welfare of subjects involved in human research that is overseen by this organization. But at the same time, what we really want to do is foster a high caliber research culture through the support of investigators. And which is why I compliment everyone here, because you're taking the time out of your busy afternoons to come and listen to someone, go on and on about informed consent and IRB, in the hopes that you will learn from this and be able to do a better job when you're there, either as a study coordinator or as a researcher, trying to be able to do a better job of protecting the rights and welfare of your subjects and participants. We review protocols, new amendments, reportable new information, organize IRB meetings, monitor, educate the research community. This is what the HRPO does. Okay? What's an IRB? It's a group or committee that, the way I view it is, we're the kind of the judicial component of this review and regulatory process. Okay? The federal regulations have devolved to the institutions to put together a process for reviewing research, and we function as the component that makes a decision as to whether or not it's ethical. Okay? Again, benefit versus risk. By federal law, it has to have both scientists and non-scientists, so community members ideally. And in a substantial portion of our meetings, we're supposed to have both affiliated and unaffiliated. So we're looking for people. And so if I may make a shameless plug right now, if you guys know of anyone who is either here and is interested in becoming a member of the IRB, or community member or a non-scientist, please let us know. Because we're always looking for good, thoughtful individuals to sit on the committee to help us do a better job. And in particular, we're always looking for folks from the VA because they have to be on the IRB when we review a VA protocol. So that's my shameless plug for the moment. Moving on. This is the smiling face. That's Dr. Rosenthal right there. So, and some of the other vice chairs here. We meet multiple times. If you get a protocol that's deferred, in the old days you'd have to wait like 4 weeks before it could go back to another committee. We have 3 meetings a week. You defer this week, we can get it on. If you respond, the letter usually takes maybe 5 days to get out to you by the time we've done all the processes. If you respond right away, we'll get it on a committee within 7 to 10 days. We're very quick at it. If you look at our statistics, our metrics, and you can see these online, if you go to the HRPO, you'll see that our metrics are by far better than most IRBs around the country. Okay? Affiliated, non-affiliated, scientist, non-scientist, VA. Again, shameless plug, please send your folks down to us and we'll be happy to get them involved. Okay? When we review this protocol, we're looking to make sure the benefits outweigh the risks, subjects are adequately protected. Again, recognizing the pre-review by the department should really look at the science of the protocol. We'll get occasional protocols that come through that, I had a protocol the other day that wanted to do a pilot study with 9 different groups. And I'm like, I'm not sure that you're going to get much out of this. And so really have to question whether the science of this is going to, the benefit is going to outweigh the risk, okay? Appropriate informed consent, confidentiality, data safety monitoring. These are all things that we review. But again, the emphasis on this presentation today is the appropriate informed consent. It's really critically important thing to emphasize here one thing, which is that the PI is the key player in all this, okay? Is a key, but it's the critical component in the context of high quality research and the assurance of human research subject safety, okay? So the PI is the one who knows the research, knows what's going on. If there's a problem, they need to let us know, because we won't go out. Well, occasionally we'll do spot audits, but as a general rule, there's a reason we come out and do audits. Sometimes not, but usually there's a reason. And it's much better to let us know in advance so that we can help. What we've gotten feedback is, this is all regulatory process. We've been audited or been oversight by OHRP, by the ORO from the VA, from HRPP, which is our accrediting body, probably once a year on average for the last 10 years. So we've kind of gone through this. You as researchers and research community can get audited perhaps by the FDA and others. The folks that have been audited by the FDA, often just routine monitoring, uniformly come back and tell us that they went through pretty well because of the fact that we keep things together in a nice way for you guys. This is part of the whole process, recognizing that research is a regulated function, and we want to make sure that we do a good job at it. Okay, and that's where Cicero comes in. So Cicero is not always the most user-friendly, though. I don't know if anyone's from the campus. I think COIS is actually much more difficult. I don't know if any of you have ever used COIS. It's truly not intuitive. Cicero, though, has its pluses and minuses, but what's nice about it is it documents everything, so that if you need documents of communications with the IRB, it's there. It specifically, as you go through and answer questions, it'll develop specific components that you have to answer, so you don't have to answer questions that don't make sense. Now, if you're coming across something that doesn't make sense, then you need to ask why. So there was something I saw recently where they were answering, they had, somewhere early on, they had marked that it was a clinical trial when it wasn't, so they were answering all these not applicable, not applicable. You have to ask yourself, oh, where did I go down the wrong algorithm? But in general, it's pretty focused and pretty clear what you're going to have. Okay. Again, it's to reduce administrative burden, though I know sometimes it doesn't feel that way. Improve consistency, improve efficiency, improves accountability, and it's modifiable, so all those who live through Gen 2 can testify to that component. And here's a typical checklist or worksheet that we use as we review stuff. The point here is not the detail. The point is that we try to do this on a systematic, reproducible, and clear process. So if you want to know what your protocol is being graded on, you can go online and look at our checklists and look at our worksheets to be able to understand what we're looking at and why. But the purpose of today's talk was to talk a little bit about exception from informed consent and waiver informed consent. And so I'm going to finish up by talking a little story. And this story started, I guess about 6 years ago now. And there was a neurologic emergency treatment and trials network, or the NET network, out of Michigan. And their NIH-funded network to look at neurologic emergencies, okay? Strokes, seizures, those type of things, brain trauma, okay? And it's very clear that if you're looking at an emergency, that you might need to consider exception from informed consent, or an EFIC. And so if you go on their website, this was on their website. And one of the studies they did, and this is our case report, or case, my single case, so I don't have to get IRB, it's just a case report, was to look at the use of anticonvulsants in seizures in a pre-hospital setting. And specifically, it was called RAMPART, Rapid Anticonvulsant Medications Prior to Arrival Trial, or the RAMPART study, which ultimately got published in the New England Journal. And it was to compare the efficacy of intramuscular midazolam with that of intravenous lorazepam for children and adults in status epilepticus treated by paramedics. Okay? So let me ask you some questions. When we're talking about exception from informed consent, the first thing we gotta ask is this an emergency condition? Status seizures. Will people die from status seizures?
They can.
They might. So for me, this seems like an emergency condition. Okay. Preclinical, or actually clinical practice at the time, it was unclear whether IV lorazepam versus IM midazolam was the better treatment, or whether they were equal. Why does it make a difference? I don't know if any of you have ever worked in an ambulance, but starting IVs on a seasoned kid ain't easy. Okay. Even a seasoned adult, it's not easy. So if I can give them a shot in the arm versus getting an IV established, I might be able. It might make a difference. Okay. And the window, remember, these are things that we have to look at. The window of therapy is very short. If these people seize for 15 to 30 minutes, they could die, depending on how bad the seizure is and the type of seizure it is. So unable to consent, potentially life-threatening condition, time-sensitive condition, prior studies supported the research. Everyone okay with that so far?
Was there an established standard of care?
One of the two agents, I want to say the IV diazepam was approved. The IM midazolam was not. Okay? But both were being used on a clinical basis. So the answer is no, there was not a standard of care. There was one that was approved and one that was not, but standard of care was what the jurisdiction decided.
Both on-label uses?
The IV diazepam, I believe, was labeled. The IM midazolam was not in this setting. Okay. So to get the approval, it was a long process. The first thing was that on the network level, there was an extensive conversation about exception from informed consent. And this was 6-8 years ago, and a lot of the thought about community consultation, a lot of those kind of questions were a result of this process. And in fact, some of the people that were in that JAMA article, in that consensus conference, were also involved in this as well, because it was all an outgrowth of this process. So there's a network level review and a site level review. Okay? Here, we had to look at the community consultation plan, and we had to make sure there were community meetings, there was identification of target groups, so they'd go to clinic where seizure clinics so they could talk to the specific population. There were media announcements. And one of the important components in addition to that is that people get an opt-out bracelet. Okay? But if anyone who knows who's done research, it's very clear that opting out, you're going to get much more likely to have people remain in than to actively opt out. But you had to give them that option. Okay? So in the community consultation and the notification of the community, there had to be a process available so that people could say, I don't want to participate. Informed consent, even though we're getting exception from informed consent in this process. So what was the whole process? So in 2008, January, they started a network EFIC study. They got an FDA investigation of new drug for the IM midazolam, I'm pretty sure. And in the end of the year, so it took them a whole year before it was submitted here as an IRB protocol. Okay? We then worked with them, and the initial review was January, multiple back and forths. We could not approve it until they had done the community consultation plan, so they kept getting deferral after deferral, which This wasn't, they knew the process, so they were clearly aware that that was, until at last, in October, we had gone through all the different required steps to be able to give them approval. Okay. We approved them for both adults and children, and anyone who does research in this state knows that children are a vulnerable population that has specific state regulations related to their research. This is a pre-hospital research, so it then had to go to MIMS, which is the EMS state jurisdiction, state agency. They approved it ultimately. It took them, I think, another year or a number of months, but not for children. So they finally got approval towards the end of the whole research, but this is the process they had to go through. Again, pediatric research in Maryland, pre-hospital research in Maryland, and I don't know if anyone's heard, I mean, there have been a number of times over the years where you'll see media about they're doing research without consent. And maybe it's a pre-hospital blood substitute for trauma. That was one case. And there's others as well. And there have been other exceptions from informed consent controversies. But here in Maryland, it's pediatric research and pre-hospital research. In the end, it was approved. We were not the worst part of the process. Actually worked very closely with them, and I think it went relatively well. Though in the end, the number of people they recruited was very small. Okay. So I'm going to go ahead and finish up, and I want to again emphasize there are two different things we're talking about. Waiver of informed consent, or alteration of documentation of informed consent, in which you're minimal risk, okay, that it's not adversely affecting the rights and welfare, that it's not practical to do the research. It's not that it's not practical to get consent. It's not practical to do the research for scientific reasons, and that you're going to inform participants if there's any new information or anything that you feel they need to know about. So that's waiver of informed consent versus exception from informed consent for emergency research, in which the burden is much higher and that you need to get community consultation and a very long process to be able to get an exception from informed consent. But we do both. There are some institutions, I presented something similar to Rochester, and part of the reasons I was doing that is because Rochester had a history a number of years ago where exception from informed consent was poorly used, and they haven't done it for a long time. And there's a lot of controversies for them to consider doing something like this. But here we do both. Now, how often do we do an EFIC study? 2 or 3 maybe in the last 10 years? They're not very common. How often do we do waiver informed consent? All the time. How many retrospective chart reviews that we approve on a daily basis? You know. So just be clear that there are differences in the different expectations and different requirements. I think with that, I'm going to go ahead and stop. I thank you for your attention and look forward to people having their friends come down to join us at the IRB and also any additional questions. Thank you. Go ahead.
So what's your suggestion for a PI who might be taking on a research project like this before they get into Cicero and hit the final submit button? Right. Is there a way to bring these types of projects to the IRB in their earliest form? Yeah,
what I would say is there are a couple of things. First of all, the ones that have been most successful is if you take the exact language from the Code of Federal Regulation and answer each of the components very clearly, then we know that those have all been done. But what I would say is that we can sit down and work with you on that in advance. And both Dr. Rosenthal and I have experience from different perspectives in terms of EFIC studies, either reviewing or putting one together. And the key here is to have a communication, have a dialogue, so we can work with you in advance, recognizing that once you submit it, it's going to be deferred as you do the community consultation plan. But let's see how much of this we can get done in advance so that when you submit it, you've got a confidence that we'll understand most of what's going on and can help support you in that process. Good question. Other questions? All right, go ahead.
Would the Amish community qualify for the community consultation?
Yeah, if the research I'm doing relates to the Amish community, and specifically to the Amish community, then that's a clearly identified community. And as long as the research specifically was focused on them, then the answer would be yes. The key is to be clear in terms of the documentation how you define community. And again, community is defined in different ways. So for example, the the Rampart study, their community was not only the general community, but they also looked at specific like seizure clinics and areas in which they would likely find people who had the potential for seizures. So it would depend on the research, but that is a clearly defined community. Go ahead.
Two things. Sorry to ask so many questions.
No, it's great to have someone asking questions, so I appreciate it.
So two things real quick. You didn't touch on LAR language or that process in consent. And then second, for the seizure study for the kids, could they not have included LAR language so the parents can opt the child into the research through LAR?
Right. Now remember that when you go back, even for an EFIC study, you have to have informed consent. You have to have that process of informed consent. If it's a child, the child is a vulnerable population. They're not going to give informed consent. So by nature, that you would default to the parents. So theoretically, you could have included children if they gave informed consent. Okay. And the LAR issue is a little bit different because you're still getting consent with an LAR, but you're not getting consent from the individual for various reasons, perhaps because they're a vulnerable population or they're in a specific. But with the EFIC study, for example, the idea is that you can't get it from the LAR. If you can, you would. But these are life-threatening conditions with a very short therapeutic window. So the ability to get that consent, even an LAR consent, is not there. But if you can, then you're supposed, even with a waiver of informed consent, if you can get consent, you should get consent. Now, someone asked me, well, gee, if I'm just drawing blood, I said, if you're drawing blood, for a minimal risk study, then you should be able to get their consent because you're drawing blood from them. Now, if you've got blood samples in the bank that you've drawn and you have no way to identify who they're from or the people are gone, well, then that I can see getting a waiver. But if you're sitting there drawing blood from someone, that means you have contact with an individual.
Let me give you a quick 10-second scenario and get your opinion on it. You have a patient for a cardiac research study who has had a embolic event and is unable to speak and or sign their name clearly. We're going to enroll them in a study. They have a power of attorney that says the children can make decisions based on life-saving measures. Can those children then enroll that patient in the study for them if there is LAR language in the consent form?
So,
because we're seeing a lot of power of attorneys that say, life-saving or life healthcare decisions in that regard, and they're very silent on research.
that is correct. The problem here that you're facing, there are multiple components to that to ask. So first, but the one that I think I would focus on is that healthcare power of attorney doesn't say anything about research. And so you're in a very gray area when you talk about that. It's going to depend on the people and depend on the relationship, but simply because they have a healthcare power of attorney doesn't mean that they have the power to say yes or no. Now, it's easier to default if they say no, not to do it. I think it's a more difficult question if they say yes. But the current healthcare power of attorneys don't specify, most of them do not specify consent for research. That's for clinical care.
Our default was to no.
What?
Our default was to no.
Yes, and I think that's the safer default, especially in that situation. Now, if you put that as an EFIC study in which you're not able to get consent, but then again, there's a huge process to that. The one advantage to that is you may be able to do some type of community consultation with the very, but again, everyone is different. It's like the question you asked. It's a complicated question, and every protocol is unique, and you have to look at those components. The federal regulation gives you the guidelines. If you can respond to all those questions and come up with reasonable answers, we're happy to look at it and to work with you on it. But again, from a power of attorney perspective, yeah, it's a slippery slope because it's not been well defined in the literature. All right, thank you very much.